today. I was telling Dr. Costilla that her class pretty much sold out pretty quickly after the catalogs hit mailboxes. So we are very excited to have her. We have over 21-ish people online because they couldn't get into this classroom. So all of you are lucky ducks right now. So so happy to have you guys. Dr. Costilla, oh, are we good to go, Susan? Good. Okay. Dr. Costilla is a distinguished gastroenterologist based in Lubbock, Texas, with over 10 years of experience in the field. When I first met her at UMC, I thought, wow, what a powerhouse. I need to figure out a way to be her friend. So let me tell you why she is so impressive and is so impactful to patients and everyone that she encounters. She serves as the medical director of the Endoscopy Center at University Medical Center. She is the division chief at UMC Gastroenterology Clinic, and she is the associate program director for the Gastroenterology Fellowship Program at Texas Tech University Health Sciences Center, where she provides medical education to the next generation of gastroenterologists. Dr. Castillo is an active member of ACG, which is the American College of Gastroenterology, and AGA, American Gastroenterology Association, which reflects her ongoing commitment to professional development and excellence in her field. Dr. Castillo earned her medical degree at Texas Tech University Health Sciences Center, School of Medicine, her internal medicine residency at the Mayo Clinic Hospital, and completed her gastroenterology fellowship at UT Health San Antonio. Fluent in English and Spanish, Dr. Castillo is committed to providing accessible and empathetic care to a diverse patient population, offering a comprehensive range of GI services, and she's dedicated to raising awareness about the importance of screening for colon cancer, especially in the younger populations, like my youngest daughter, who was one of her patients, as well as the young at heart people like you and I. And also she does all of this for the betterment of her patients and the community that she serves. Please help me welcome my friend, Dr. Vanessa Costilla.
Okay, everybody hear me fine? I'm gonna try to stay close to the mic. I tend to back up sometimes. Thank you for having me today. What an amazing, I did not know about this organization that you guys are a part of. This is really fantastic that you have the opportunity to hear different speakers on various topics. So the aging gut, how time, stress, and tacos impact digestive health, right? So all right, so let's hope my transitions here go okay. So the big, let's see. Are we not working? Am I just? Frank. Hey, Frank, we need help. We're frozen. Okay, okay, there we go. All right, always need IT. Okay, let's try. Okay, perfect. Okay, I should be able to go back, he says. Okay. So our agenda. So we're going to understand the aging process of what happens to your gut, all the digestive organs, right? So as a gastroenterologist, oh, and I see some friends. Hi. As a gastroenterologist, right, we want to know, we don't just take care of your gut, your esophagus, your stomach. We also care about your liver and your pancreas. Those are all your digestive organs as well. So I'll hit on those as well. The role of stress in gut health, the impacts, dietary impacts on digestive wellness. So focusing on our tacos and spicy foods, just because it's a catchy title, of course, and maintaining digestive health across your lifespan. So understanding the aging process in the digestive system. So this is really, we're going to start at the mouth. We're going to go through each from the beginning to the end, okay? So the oropharynx, right, which is basically your throat, your mouth region, okay? So that lining starts to thin with age. We know that taste can change as we get older. Your gums can recede. You can have increased cavities, which can result in tooth loss and all of these things. So patients obviously who lose teeth, who have difficulty with chewing, often will have inadequate nutritional intake. And then if you're not chewing very well, right, then that can potentially impact your swallowing. And we'll kind of get to that as well. We also know that your salivary glands, up to a 50% decrease in your saliva production, right, which when you're not making a whole lot of saliva, that increases your potential damage to your teeth. And up to 50% of older patients, wiser patients rather, have subjective complaints of dry mouth, which can again impact chewing and swallowing. So these are all things that start to happen. And we know that breakdown of food, it starts where? It starts in your mouth, right? All right, so when there have actually been studies that show that the transfer of the food bolus to the pharynx, okay, so that act of swallowing, which is actually a very complicated process, is actually altered in the majority of older patients, even if they aren't symptomatic, right? So those changes might be happening already, but they're not necessarily noticing those results enough to bring it up to their physician. The loss of esophageal muscle compliance results in increased resistance to flow across the upper esophageal sphincter. So as we're trying to get things into our esophagus, we don't have that compliance, and so therefore things are maybe lingering where they should not be, which increases your risk of aspiration. The strength and coordination of your tongue also is impaired. Even in healthy 80-year-old patients, they noticed a change in their coordination. And then again, we kind of hit this earlier, less effective mastication and decreased food clearance from the pharynx increases risk of aspiration. So in this photo, do I have a clicker? Does this have a pointer here?
Oh, it does.
It doesn't. Okay, so I'm gonna see if I can use my mouse. No. Well, for those of you, I will point. You can see where the red arrow, that is basically liquid going into the trachea instead of going where it should be in the esophagus, right? And this is the problem we see a lot in our aging population. They notice, okay, I'm having trouble, I'm choking on, especially like thinner liquids, they start to have trouble. So we do a modified barium esophagram to really assess for aspiration. Is the liquid going where it's supposed to go? So in the esophagus, so there's a few like anatomic changes. It may be nothing to you, but basically there's hypertrophy of the skeletal muscle in the upper third of the esophagus. The esophagus is made of different types of muscle, and so we know that this happens as we age. There's decreases in the ganglion cells that coordinate peristalsis. There's increased smooth muscle thickness, and all of these things result in functional changes. So the amplitude of esophageal contractions during peristalsis decreases, but sometimes the movement of food is not necessarily impaired. We now have what we call high resolution manometry. This is a really fun test, guys. I mean, patients love doing this, and this is with major sarcasm, okay? This is a test where we basically insert a catheter into your nose, okay, and down into your esophagus. And basically it gives us these really great pictures of what happens to your esophagus when you swallow liquid. And it gives us exact pressure measurements. Is your esophagus squeezing sufficiently? Is it relaxing sufficiently? And so it measures all of these things. And so using high resolution manometry, subtle changes have been noted. Even in healthy 70-year-old patients, the upper esophageal sphincter and esophageal body pressure responses to large versus small volumes were altered in those patients. These were healthy volunteers. That's pretty impressive, actually. They were willing to do this for these studies. Abnormal peristalsis after swallowing and non-peristalsis. So this is kind of complicated esophageal stuff, but basically we see the altered motility of your esophagus as we age, unfortunately. Okay, so further functional changes. So diminished secondary contractions of the esophagus that contribute to like clearing the esophagus of your food. When you swallow, like making sure it leaves the esophagus completely, are greatly reduced. And therefore you may reflux things, or things linger in your esophagus longer than they should. Diminished lower esophageal sphincter tone, again, increases acid exposure from the stomach. And then the sensation of distension and possibly tissue damage in the distal esophagus is also impaired with age. So then patients, I have a lot of patients who say, I don't feel anything. I am not refluxing. You're crazy. There's no way I'm having reflux. And their esophagus looks like this, right? And it's because the innervation, they're just not feeling like they otherwise would. And so these are some pictures in that top, your right corner. These are esophagograms, and we can kind of see that the esophagus movement is a little bit discoordinated, and it's not completely normal. And the bottom picture there is of an esophagus with ulcerations and inflammation. So we call this esophagitis, and that, like I said, patients can have horrible looking esophagus like this and report minimal symptoms or feel like they don't have true reflux. So in the stomach, you are still able to acidify things. So 90% of patients over age 65 are able to acidify their gastric contents. Previously, we used to think that that wasn't the case. We used to think that you were not making acid as well as you should as you age. Now we actually think, now we know about H. pylori, which is a bacteria that can occur in the stomach. When you have H. pylori, actually that can alter the pH in the stomach. And so we think that might have been what altered those initial studies. You have increased sensitivity to gastric irritants, right? So like NSAIDs, our favorite for arthritis and joint pain. We like to use our ibuprofen and Motrin, Aleve, all of those lovely things. And as we age, our gut is, especially our stomach, is much more sensitive to those things, which can result in gastric ulcers. And we think this might be because we are maybe not producing as much prostaglandins, decreased bicarb, all of these things, impaired microcirculation. So your stomach is actually a very vascular organ. It has lots of like dual blood supply, but certainly as we age, if we have cardiovascular disease and the blood flow isn't as good as it once was, that certainly can alter the healing of an ulcer. Perhaps it would happen faster it will happen faster if your blood supply is very good to that area. If it's altered, it will be certainly much slower. And then delays in gastric emptying. So the cells that control emptying, these cells, the interstitial cells of Cajal bodies, basically they decrease by 10% per decade in normal people. This is just what happens, even those without symptoms. And so we do think that this can alter emptying of the stomach. Okay, in the small intestine, we will see some villus atrophy. You have decreased vitamin D receptors, again, decrease in your sensory and movement nerves. And we also have decreased lactase enzymes, and I'm going to really expand on that later. In functional changes, because of these changes in the villi, right, these are this is what helps us absorb our nutrients, right? So therefore, we tend to see then functionally a decrease in absorption of a lot of our micronutrients, B12, folic acid, calcium. We know that women over age 75 will absorb 25% less calcium than younger women when given that same dose. The small intestine transit time does not appear to be longer as we age, which is a good thing. That keeps moving, thankfully. In the colon, we might see the lining of the stomach atrophy, get a little thinner. And there's a lot of other aspects, again, changes in sensory neurons, which decreases like your quote unquote visceral response, right? So you are not feeling things as well as you normally would. Functional changes, altered coordination of contraction. Your colonic motility is reduced. There was even a colon transit time was doubled in a study of older patients compared to younger patients. And they did this using, there's like a smart pill that actually measures how long it takes for this to leave your colon. And so that was an interesting that it actually is that study was done. And actually I didn't know that initially. I was like, okay, this is very interesting in my research for this presentation. So the last thing, the anal sphincter. So we have decreased anal sphincter tone as we age. We see resting and squeeze pressures are less. Male and female patients over age 70 had a 30 to 40% decrease in sphincter pressures compared to controls that were 30 years younger. And so this can, and there's lots of things that can impact that, right? Like for our female patients who have trauma, right? They had delivered large babies or had a forceps delivery and there was trauma to the sphincter, like obviously that increases their risk even further. And even, and we can, I'm sure that's a whole different topic, but like postmenopausal changes, right? The fullness of certain areas alters with age as well as areas become thin. You might have been able to compensate for it when you were 40, but when you're 60, maybe that compensation is not as robust. So liver, like I said, digestive organ, another one. So the liver mass decreases between 20 to 40% with age. The blood flow decreases between your third and 10th, that's a long time, 10th decade of life. Your standard liver function tests, however, are usually minimally affected. So these changes are happening, but your liver test that your doctor is checking should remain normal. Though we do know that the function, more subtle changes that are not always measured in your blood work, are declining, right? So less erythromycin, demyelination, you might not clear the caffeine that you consume as well as you did before. You have reduced metabolism of LDL, which results in higher serum LDL, right? So sometimes you're like, well, why? I've never had high cholesterol, high LDL. Why is my LDL going up as I'm getting older? And it could be for these things, even if you're eating the exact same food that you were eating before. Also one that's really interesting, so cytochrome P450, which is basically an enzyme that helps you metabolize a lot of medications. You have reduced production of this, so which results in reduced metabolism of many drugs, and so therefore 20 to 40% slower in older patients versus younger patients. So that's important for us to always know and consider. The gallbladder, our friend there, it's function, anatomy, and anatomy are overall well preserved. However, as we age, we do have higher risk of developing gallstones, mostly because the bile that lives in the gallbladder just gets a little bit thicker, okay, and so therefore it can form a stone more easily. In your pancreas, we might see a little atrophy, meaning a little, it kind of gets a little smaller, a little scarred, but usually in terms of the digestive aspect, so, the pancreas does two things, right? It helps you make insulin. For those of you with diabetes, you know about that, but also it helps release digestive enzymes that help you break down food, especially fatty foods. And really, we don't think that that should be changing much with age. Or exocrine pancreatic function is what we call that. That looks like that should be stable. However, we do see, and we can find these a lot incidentally on CAT scans, for example, as we do see dilation of your pancreatic ducts. We see formation of these sometimes pancreatic cysts. And so you can see the ducts not very well in that picture, but they're kind of throughout your pancreas there. And sometimes we'll see those on your CAT scan. We used to get a lot more nervous about those things, and our guidelines have really told us, wait, patients actually don't end up dying from anything related to this dilated pancreatic duct, right? Like we watch it, and sometimes we can even watch them once a year for a couple of years, and then we can even go once every 3 years to watch it and make sure it's not changing or progressing. But usually those are benign or slow growing things. So I liked this dragon from the Nexium commercials. I don't know if y'all remember that. I was like, I know there was a dragon for Nexium. Anyway, so acid reflux. So we're gonna start talking about like disease processes now. Okay, so acid reflux, very common, right? We see this every day in a GI clinic. It affects 20% of US adults. It increases with age, obviously, and obesity as well. And we talked about why, right? Because that you're not clearing the esophagus as well, or that lower esophageal sphincter is very relaxed and letting things flow back up, and that is happening with age. And we also know that it also occurs more in certain types of bariatric surgery. So patients who have like a gastric sleeve end up with a lot of reflux. I'm not saying you shouldn't do a sleeve. No, I'm not saying that at all, but just know that that's a possibility. The lap band, which is not really done much at all anymore, also increases your risk of acid reflux. So symptoms. So acid reflux, people are like, I don't have reflux, right? But when I am looking or asking, these are all the symptoms you can have. You don't necessarily just have to have classic heartburn symptoms, right? People will come in with chest pressure, chest discomfort, a chronic cough. They're like, I'm constantly clearing my throat. They have hoarseness, a sore throat, trouble swallowing, or they'll say food is catching or hanging in their esophagus. I've even had patients who have horrible ear pain, which is really strange. I remember when I learned that in fellowship, I was surprised. I was like, ear pain? Yes, if they're refluxing so bad at night, sometimes it actually hurts their ears. So there's lots of different symptoms of acid reflux. And so the workup, sometimes we might just give you a medicine to see if you respond. You might like Nexium or pantoprazole or omeprazole. There's lots of different acid reducers. And we assess, do you respond or do you not respond? If you respond well, yes, this is likely acid reflux. For some patients, we offer them an upper endoscopy, especially if they are not responding to an acid reducer or if they have other alarm symptoms. Like if people feel like food is catching in their esophagus, that is concerning. We should probably take a look and make sure there's nothing scary like an esophageal mass that could be in their esophagus. And then there's lots of other tests, an esophagram, which I showed you a picture of earlier, the manometry test, which is not fun, it's that catheter in your nose. And then we have some really cool technology that I'll show you here shortly, that called a pH monitoring. So this is some endoscopy photos. So this is a picture of a hiatal hernia where that big red arrow is. So in this patient, you can see even like a little ulceration on the left there. And this patient has a good portion of her stomach above the diaphragm in her chest, right? So therefore, reflux is very, very hard to control. On the right side, you see where it is, and my picture is not so great on this screen, but the esophagus lining normally is a very pale pink color. And you can see that more salmon colored lining is something we call Barrett's esophagus, which is a precancerous change of the esophagus that occurs in patients who have chronic reflux. And so if you've had reflux for 10 or 15 years, and then there are certain people that are even higher risk, male patients, obese patients are even higher risk of Barrett's, we will actually want to screen you for this. We'll do an endoscopy to make sure you don't have Barrett's because we will want to monitor this and make sure it doesn't progress to esophageal cancer. And then on the bottom there, that's another photo of esophagitis. Again, horrible inflammation and ulcerations of the esophagus due to uncontrolled reflux. So the esophageal manometry, that's the test that I told you, apparently some healthy people volunteered to do. I've never done this before. Kathy, my friend here, has done it before, and she is so good at talking to the patients because when you've actually endured it, right, like you can explain to them like and what to do and how to get through it. But yes, we just numb that nostril and then insert the catheter down and then get really good like I said, numbers and data on how your esophagus is functioning. And this is important for the surgeons as well, because let's say you tell me, I don't want to be on a medicine. I worry about those acid reducers. They say they're bad for you. I'm not going to be on them long-term. And you have a big hiatal hernia that needs repair. These surgeons will make you do this test because this helps them plan for your surgery to make sure that they don't, if your esophagus, for example, is very weak, if it's not squeezing, it doesn't have a very good squeeze, and then they go and wrap, and I'll show you a wrap here shortly, wrap the end of the esophagus very tight, what's going to happen? things are not going to go through, right? And so you're gonna end up with a bigger problem. So the manometry is very important for the surgeon before he operates and does an anti-reflux surgery. And then this test on the right, so this is pH testing. So a long time ago, we used to insert a catheter into your nose and leave it there for 24 to 48 hours. And you'd have to go home with this little catheter, and it was measuring acid in your esophagus objectively, like telling us how severe objectively is your acid reflux. And this would also help the surgeons decide, should we really operate on this person or not? And thank goodness for some technology, because now we have something called the Bravo pH capsule, which we actually, during the endoscopy, I will attach a little tiny capsule to the end of the esophagus, and it uses Bluetooth to this and sends it to this device that you wear on your hip for 2 to 4 days, and it objectively measures acid reflux. You don't have to have anything coming out your nose for 4 days, which is so much nicer. And this is really important because there are some patients who feel like they're refluxing, but maybe really aren't, right? And we certainly don't want to do something like a surgery on those patients if they're not truly having acid reflux. And so this helps us really flush through all of that and to determine, are you really a good surgical candidate? Or is your reflux so severe that yes, you really need to stay on that acid reducing medication, despite the risks you may hear about, right? Because it's always a weighing the risk versus benefit of any medication. So objectivity is important. So, okay, so how do we manage reflux, right? So lifestyle modification. First, if we can do it with that, of course, that's what we want. We don't want to just have to give you a medicine if we don't have to. So weight loss is a huge thing. When patients lose weight, we know that sometimes their hiatal hernias are a little bit smaller and that they don't reflux as much because they may have less belly pressure, or external pressure pushing on their abdomen. We can also tell patients to elevate their head of the bed, ideally 6 to 8 inches. And now there's lots of beds out there that are kind of designed for this specific, to be able to do this very easily. We don't actually recommend you stacking pillows, because if you kind of ever have stacked pillows, you don't always end up in the best position. So it really is truly an elevation of the head of the bed. Avoiding late night meals and snacks. Really not eating for about 2 to 3 hours before bedtime is important. Sleeping on your left side will result in less reflux, and obviously eating smaller meals. I tell some patients, I'm like, I can block as much acid as I can with an acid reducing medication, but if you overeat, you're going to reflux, right? Like you can eat through your PPI, right? Like you can still eat so much that it's just pushing upwards onto that sphincter and you're going to reflux. So eating smaller meals is important. So dietary changes, like specifically food, like caffeine, coffee is a huge trigger of reflux. We all love our coffee and it's really good for your colon, but it definitely can make you reflux. Chocolate, peppermint, all the good things, citrus, tomatoes, spicy and fatty foods, right? All of the great things, avoiding or limiting alcohol and carbonation, things that are going to make you belch. Those are all important to do. And so now let's kind of talk about medication. So you've all seen these, right? Over the counter, you can buy them. Your antacids are like Tums or Rolaids. H2 blockers, that was like Zantac back in the day. Now it's famotidine that we use a lot. And then Nexium, Zagrepov. There's so many, and they all have different, honestly, potencies, right? So if one of them is not working for you, don't think that none of them are going to work for you. Sometimes we just have to put you on a stronger one. And so you should talk to your doctor about that. And we even have some brand new, probably approved just over a year ago, potassium channel blockers, or like even stronger than the PPIs. And so we have used some of those in our patients as well. So these are the surgeries that we can offer for anti-reflux, for reflux management. So fundoplication. So basically and you can see in that picture on that, they're basically wrapping part of the stomach around the lower end of the esophagus, right? And so depending on your manometry and your symptoms, they may do a full wrap where they do a complete, 360, or they may do a partial where they kind of only wrap it around like 180 degrees and not completely. And so the surgeon makes that decision based on those studies. Obviously fixing the hiatal hernia. So if you have a good portion of your stomach above the diaphragm, we pull it back down below the diaphragm where it's supposed to be. And then there's another device called the Lynx system or Lynx procedure, where this is actually like a bead of magnets that they put at the lower end of your esophagus to keep you from refluxing. And so some patients rather have that. And so obviously if you have a lot of MRIs and things, these are like MRI conditional. There's some magnets you wouldn't be able to utilize if you have this, but some people like this better because they feel like it isn't as invasive as a fundoplication. Okay. Chronic constipation. This is also a very fun topic. Okay, so there's various types of constipation. Okay, and so a lot of the things that the words that we use. So chronic, idiopathic. We don't really know necessarily why you have constipation. If it's a chronic constipation, irritable bowel syndrome with constipation, opioid induced, right? So you've got patients who just have to be on pain medicine and their gut is going to be very, very slow because of it, and we have to treat it. Slow transit, meaning probably not on opioids, your gut is just slow, it doesn't like to move. And then one that I feel like is often forgotten, especially in, well, honestly, all patients, but I feel like especially our female patients, is pelvic floor dyssynergia, where basically we're not relaxing relaxing our the anal sphincter enough to let the stool out. So let's hit on some of these. So chronic constipation, and whenever we are talking to you, we're going to get a very detailed history to figure out how to manage this, right? One of the things we want to know is your family history too, right? Like, is this new constipation? Is this old constipation? Do you have a high family history of colon cancer, right? This is going to kind of alter potentially what we offer you in a workup, okay? Surgical history. Did you have a hysterectomy, multiple belly surgeries that could be resulting in adhesions that could be impacting the movement of your colon? Pelvic trauma, like birthing large babies, right, can impact the rectum as well. And then medications, right, like blood pressure medicines. I don't know if you knew, some of the blood pressure medicines you take could be making you constipated, right? And not that we should stop them, but you should know that that might be part of what's going on. The GLP-1, so all the weight loss medications, those are also the diabetes, the Ozempic, the Mounjaros also slow the emptying of your stomach and your colon as well. And so assessing all of these, calcium supplementation, and also realizing, and I think I have a hard time convincing some of my patients of this, that they can be constipated but be having diarrhea, right? Like, I think that's a hard thing for people to understand. If you're so constipated and the only thing that's going around those very hard impacted stools is liquid, then sometimes we actually fix your constipation or fix your diarrhea by treating your constipation. And so that just requires a lot of education from our part to make sure we're explaining that well. We use a nice fun poop chart called the Bristol stool scale. I'll show you a picture of that shortly. And then lastly, I said assessing for pelvic floor dyssynergia. So we ask you lots of questions. So one of the things I'll ask my female, is it hard for you to push or pass stools that are even soft or liquid, right? Like, if you are having a hard time getting out a liquid stool, even though liquid stool, that tells me that anal sphincter the door is closed. It is not letting it, if you're having a hard time getting liquid out, then maybe that muscle is just too tight and not relaxing. And then splinting. This is another thing that some of my female patients don't always want to volunteer, where basically they have to push on their vaginal wall to be able to get the stool to come out, right? Because they may have something called a rectocele, which is basically when part of the rectum is pushing into the vaginal canal, right? And so these are all things we assess. So this is the poop chart. I have one of these in every room, in our exam rooms. And basically that is the question you get asked, whether you have symptoms or not. Actually, I'm like, okay, how many times do you poop a day? And what does it look like? What's your number? 1 through 7. This is what you get asked. And so obviously we are aiming for a number 4. That is always what we want. That is normal. And so we kind of, this will be in your chart when you see me, because sometimes people, right, constipation for people means different things, right? They're like, oh, well, I poop every day. I'm like, okay, but what does it look like? If you're pooping number 1s, that's constipation still, okay? So we don't want you to have hard stools that are hard to get out. So just making sure we flush through that is important. So what is the job of your colon, right? So the number one job of the colon is to absorb water from the stool. And so if you are dehydrated due to exercising too much, hot weather, right? Medications that you take that dehydrate you, that Lasix, right? That help with your leg swelling can also dehydrate you. If you're not drinking enough water, basically your colon is going to try to salvage as much water from your stool as possible. And therefore it's going to lead to dried out hard stools that are harder to get out. Sorry, I have all these transitions. Okay, let's go back here. So like number one, two, and three, which is what we do not want. Okay. So dietary fiber, that's kind of the first thing we tell you. Eat more fiber, right? What does that mean? How much fiber is that? So we really recommend about 25 to 35 grams of fiber per day. Like who actually thinks they get that much? Anybody? Oh, one person. Okay. I mean, honestly, like if you actually measure your fiber, I have to think about my own day today. It's like I had coffee this morning, right? Like if I try to really shove 25 grams of fiber when I eat dinner tonight, which is probably what will be my largest meal of the day, right? I'm not going to achieve it. It's just not going to happen, right? And that's how most of us, I think, live. We're like, we are not going to get 25 to 35 grams of fiber per day. And we often don't even know, right, how much fiber is in each of the foods that we eat. And so one of the things I learned, I mean, think about it. If you think about raspberries versus strawberries, you'd probably be thinking you're about getting the same amount of fiber. And then look what a difference it is. Raspberries actually have way more fiber than strawberries. 8.4 grams versus 3.4 grams, right? And so I learned that several years ago reading this book it's called How Not to Die. Has anybody ever read that book? It's such a great book, right? It talks about all the dietary things. And I was like, what? Raspberries have the most fiber? And yes, they do by far. And so this is just a nice, so prunes clearly have a lot of fiber also. So this is just nice for you to kind of see, okay, wait, if I really need to get some bang for my buck, what do I eat? Lentils. You eat a whole cup of boiled lentils, you might be very bloated afterwards, especially if your body is not used to consuming that amount of fiber. Okay. So there was a really great study a few years ago that actually assessed, so kiwi, right, improving constipation, because patients like that, they don't want to be on medicine, and I get that. But basically they compared 2 kiwi a day versus psyllium, which is Metamucil. And they basically were equivalent. I mean, basically you can have 2 kiwi a day. That's basically like taking a Metamucil supplement. And I think that's great. So if I have patients who don't want to take anything, let's try 2 kiwi a day if you like kiwi, or eat a cup of raspberries a day and see where we land, because that's nice. Let food be your medicine. It is important to know that not all fiber supplements are the same, okay? One of my favorite fibers is Citracel because it's soluble fiber. It basically results in less bloating, especially for people who tend to not eat a lot of fiber to begin with. One of the biggest complaints is if they go and eat a ton of fiber, all of a sudden they feel very bloated, their gut is not used to it, and they do not feel well and they don't want to continue. So Citracel is great. Metamucil is psyllium husk, as we talked about. It has the most data, though really all of our data on this isn't very much. Nobody wants to do randomized controlled trials, right, on things that are already FDA approved and on the market, right? So it's harder to get some of that data. Hydration is very important when you're on a fiber supplement. One of the things I'll have patients tell me is like, oh, I tried that and it made my constipation worse. And most of the time that's because they did not drink enough water, okay, with their fiber supplementation. So that is important. Bloating, again, most significant side effect, and we want to titrate up slowly, okay? And then I personally do not like to take powders and liquids. That's just not how it's going to work in my world right now. And so caplets are a great thing to consider, and you can get fiber in lots of different forms. And so caplets is what I actually favor. So again, food be your medicine, hot beverage or coffee. Drinking a warm beverage, especially with caffeine in the morning, actually stimulates gut motility. We know that, right? And so coffee is good for your colon. In 2017, there was a study that showed that coffee consumption lowered your risk of colorectal cancer by 26%. That's pretty impressive. 1 to 2 meaningful servings, okay? So more than 2.5 servings resulted in a 54% reduction in colorectal cancer cases. Like, that's really impressive, honestly. And, but if you have reflux, you have to be careful, okay? So you have to weigh it all. But coffee is really good. And actually, because of this study, I started to actually drink coffee. I drink coffee now because of that study. I was not a big coffee drinker before. Probiotics, that's a big topic, right? Everybody's like, what probiotic should I take? And actually, right now, we don't have, again, enough data on any of these probiotics to say that you should use them to manage constipation. Okay, I'm not saying they may not be beneficial for other things, but in terms of constipation, if you're going to buy something over the counter to manage, I'd much rather you do a fiber supplement, because that is actually going to be more helpful to you than a probiotic. There's really no role currently in the management of constipation. They're not in the guidelines. They do not recommend that, okay? They're just, and they recommend against using them for IBS with constipation. So just know that. Stool softeners are another thing that we'll kind of go to next. They're not usually very helpful, especially for like opioid-induced constipation. They're just not going to work. And they're not really recommended for chronic idiopathic constipation, but they're there. People say, oh, I take it. I don't know. They're not usually very, very effective. What is effective, again, my transitions are, this is what I want to give everyone, is Miralax, okay? So Miralax is what we go to first. It's an osmotic laxative. It's very affordable. I hear Dollar General has the cheapest Miralax, so my patients tell me it's very safe, and it's not systemically absorbed. It all stays within the lumen of the gut, and it does not get into your bloodstream. So that's really good, and it's durable. It can last a long time. And I will do the Miralax fiber combo as well. One of the patients might say, oh, this makes my stool too runny, I don't really like it. Then we make sure they're having enough fiber to make sure it's a little stickier. So if we could do Miralax for everyone, that would be good, right? That's like the first thing we say. That's where we start, Miralax. Magnesium. So this is a nice thing to consider. So magnesium oxide or citrate, 400 to 500 milligrams daily. The other type of magnesium that you use for sleep, okay, that really gets absorbed into your bloodstream, and therefore it is not as effective for any type of constipation. And so there have been some studies that say you could do 1,000 to 1,500 milligrams of magnesium. It's affordable. Obviously, pregnant patients, if you have like really bad, like end-stage renal disease, you need to be careful with any electrolyte supplement that you're taking. So again, magnesium glycinate is really for relaxation, sleep, but the citrate and the oxide you can use, especially the citrate, you can get that in caplet form as well, is best for constipation. Stimulant laxatives. So these Senna, Senecod, Visicodil, these colon cleanse that you see, even smooth move tea, right? Everyone's like, this is natural. Yes, it's natural. It's still Senna. It's what's in Senecod S. Okay, these are really not meant for long-term use. But if you need to use them occasionally for rescue, like let's say you had a hip replacement and they put you on Norco and you're constipated, yes, use the Senna. Okay, that will rescue you. That is fine. But it's not really great to use stimulants long-term, because they are literally telling your colon, squeeze more. And what happens is you need more stimulation to have the same effect. So I have some patients who start out taking 1, and then they come back to me a year later and they are taking 4 to still have the same bowel movement. And so that's not what we want to do. And so the other thing these things can cause is something we call melanosis. Okay, so a normal colon color is at the top. And then these are patients who have melanosis. I mean, basically their colons look purple or black. And this is all caused from this stimulant laxative. And so we want to avoid that. And this is the pathophysiology. Why? This is not causing like melanoma. Okay, so just make sure but it does make your colon very, very dark. And so basically it's kind of killing some cells, and those damaged cells accumulate and have this hyperpigmentation in the walls. And you can see that those stains there between the purple globs. You can see that hyperpigmentation pigmentation that accumulates in the cell wall, or in the wall of the colon, making it look very, very dark. The only plus of having melanosis, really, from an endoscopist standpoint, is the polyp. If you have a polyp, it doesn't take up that pigmentation, so that makes the polyps very easy to find. So that is the only plus. Okay, the lactose intolerance. This was really, really cool, actually. So to kind of really dive into this. So 65 to 75% of the world's population has lactase deficiency. Yes. Yes. Okay. So, and I tell my patients this all the time when they come in with bloating. Okay. They're like, I've always been able to drink milk. I'm not lactose intolerant, like, but you might be now. Okay. So, this really does vary across like ethnic groups, but you have to think about like mammals, right? What other mammal continues to consume milk, right? Like outside of infancy, or right? Like they don't, right? And we still are, right? And so naturally we make less lactase as we get older because we theoretically should not be consuming that anymore, right? And we do. So lactase, non-persistence, okay, the ability to digest lactose after infancy, it basically means the ability to digest lactose after infancy is like lost. Lactase persistence, okay, meaning you keep it, is actually a mutation. So there are populations, like Northern European populations, for example, where like, so on that bottom, you can see lactase deficiency, the prevalence. So East Asia, 70 to 100% have lactase deficiency. West Africans, Southern Europeans, Native Americans, right, 80%, okay? Whereas Northern Europeans in general are very low, okay, 5% or less. But basically what I was reviewing, because I'd always heard this, right, like, African American patients become lactose intolerant very young. Hispanic Caucasians are kind of next in line to become lactase deficient, and then non-Hispanic Caucasians become lactose intolerant eventually, but much later down the road. And basically, what's happened is in patient populations where they were consuming a ton of milk, that was just part of their diet, they basically had a mutation that allowed them to digest it more because that was just became such an important part of their diet. So basically, if you keep your lactase, that's actually the mutation. Everybody else is losing it. So that's really interesting. I thought. Questions about that? I know that was kind of confusing, but yes, basically everybody becomes lactose intolerant. Do not be surprised by that. That is what happens. You're not going to be able to digest things as especially dairy products as easily as you once did. So management. So we tell patients limit milk, soft cheeses. Certain cheeses have more lactose than others, right? Consume harder cheeses. Yogurt, kefir usually have less. There's lots of lactose-free products, right? You can get lactose-free ice cream. You can do all the things, lactose-free cheese. You can do the plant-based milk alternatives like almond milk, soy milk. And then of course, there's always the good old lactase enzymes, right? You can just keep them in your purse. There's patients or in your back pocket. And they basically will take a tablet, when they're consuming their dairy or their lactose containing food. And then they'll take a second dose if you're having a particularly large or longer meal. You should take a little bit more. But there's lots of ways we can manage this now. So next topic, diverticulosis. Okay, so this is also very, very common. All right, so diverticulosis, they're small bulges, little pockets or pouches that happen in the wall of the colon. They're little weak spots basically that created that bulge. And we think it comes from increased pressure in the colon. If you're constipated, this is putting you at even higher risk. If you're straining and adding pressure to your within your colon, right? That will potentially create the bulge. More common with age, low fiber diet, lack of exercise, obesity. We also know there's a genetic component basically affecting the structure, the wall of your colon. That can predispose you, just the genetic, this is, that makes your colon wall weaker. Okay. I have some patients, I had one patient, she was like 23 and had horrible diverticulosis, but her mom had diverticulosis young. Her grandma had it. They all had part of their colons removed due to diverticulosis. That was clearly genetic. Most 23-year-olds do not have diverticulosis. But lots of patients have it. 50% of adults in the US over age 60 have some diverticulosis. It's that common, okay? But most people are asymptomatic. It might cause some left lower quadrant belly pain. We will see it on your CAT scan. If we do a CAT scan, and certainly I will see them during your colonoscopy. We don't do anything about it. We tell you to eat lots of fiber. You can't get rid of the pockets once you have them, unless you have a big surgery. And we would only do that if you had if you had severe diverticulitis that resulted in an abscess or a perforation, then you might end up with surgery. But otherwise, we just note that they are there and tell you to have more fiber. Okay, so treatment, again, avoiding constipation. This is kind of how they look endoscopically. So they're just like little holes, little pockets. They can make your colonoscopy very challenging, I will tell you. It's like, which lumen? One of our endoscopy nurses in his radio voice used to say, it's time for another game of tick or lumen. Where are we going? Is it a diverticula or is it the lumen of the colon? Where are we going, right? Because you don't want to go in the wrong hole. And so, I mean, it can be very, very challenging. So yes, but I would always get a camera and say that. So again, antibiotics if you do get diverticulitis. All right, so colon cancer screening. This is obviously what I do every day. This is why I was almost a little late today, because I probably did one too many colonoscopies for this day, trying to get here by 2 o'clock. So average risk. So you now start at age 45. For everyone, right? That changed several years ago. It used to be 50, but we are seeing higher rates of colon cancer in younger and younger patients, likely due to diet. And so we have dropped the age now to 45. I will tell you, your doctor gets a report card, if you will, okay, your gastroenterologist, that tells us how good are we at finding precancerous polyps. And when we dropped the age from 50 to 45, I truly expected that our report cards would look worse, right? That they're going to say, you're not as good at finding colon polyps as you were, because we're doing them in younger people, right? Who you think would have fewer polyps. And we didn't see that at all. We were finding just as many polyps in our 45-year-olds as we did in our 50-year-olds. And so I think that tells us this was a good move, right? This was a good move at preventing colon cancer. So higher risk patients. So if you have a family history, if you have certain diseases that put you at higher risk, then you start at 40 or even sooner. And then we could do a whole talk on those diseases. But what I really want to hit on is our next slide. So how many options you have for screening and the importance of knowing the data. So this is me with my lovely polyp. Anyway, okay. So I made this fun table because I'm also going to go share this with a bunch of your doctors, okay, your primary care doctors, because these are kind of the foremost common tests that are currently being offered to patients for colon cancer screening. So colonoscopy, that's what I do obviously every day. We are looking inside your colon, right? So what do you want to know about any test that you're doing? You want to know, how good is this test, right? If I have cancer, how good is this test at finding the colon cancer? And how frequently am I going to have to do it, right? So colonoscopy, basically 100% sensitivity at finding colon cancer. Okay, like if you have colon cancer, it would be very unlikely for someone to miss it. Okay, there are rare exceptions. There are certain cancer syndromes whose presentation of colon cancer is very atypical and if a cancer can be very subtle. And so in those situations, it might be harder to find, but overall, basically a 100% sensitivity. Okay. Specificity, if it's cancer, it's most likely cancer, right? And then the sensitivity for precancerous polyps. How good are we in your colonoscopy at finding precancerous polyps? And again, 85 to 95%, we're going to be finding all those. Okay. And there are exceptions, and all precancer, some polyps are teeny tiny, right? 2 millimeter polyp that's not going to be of any major consequence in the future. But as long as you're finding those bigger ones that are going to be turning into colon cancer, that is the most important thing, right? So if you're normal, then you don't have another colonoscopy for 10 years. And if you have polyps, that depends on how many polyps you have, the size of the polyps, the type of polyp. There's lots of different, and then we kind of decide, okay, do you come back in 3, 5, 7 years, depending on the number, on all of those factors. Okay, so these are the other things that you get offered. So the FIT test, right? This is a stool-based test. Sometimes the insurance company will just mail this to you. Even if you don't need it done because you just had your colonoscopy last year, they'll mail that to you. And so the sensitivity of the FIT test for colon cancer is 79%. Right? So that's like 21% chance you might have colon cancer and did not catch that, right? If it is positive, it is pretty good, it's specific, is according to their data. But it's not very good at finding precancerous polyps, so preventing, right? So only 25 to 55% sensitivity for precancerous polyps based on various studies that have been reviewed. So missing up to 75% of precancerous polyps, and then you have to do that every year. Cologuard is probably now more commonly used than the FIT test. And it's pretty good actually at detecting colon cancer. Overall, they say 92 to 95%, but you have to remember that's where they lump in all stage 1, stage 2, stage 3, stage 4 colon cancer, right? So that's their overall number. It's important to kind of know, right? When is colon cancer curable, right? If you have stage 4 colon cancer, that's not necessarily considered curable. There's some exceptions to that now, but overall, we want to find things early, right? We want to catch things early so that it can be a curable cancer. So they're about 88% sensitive for finding stage 1 colon cancer. Okay, their specificity is pretty good. They are not great also at finding precancerous polyps, or missing still almost 60% of precancerous polyps. And you can do this every 3 years. So Cologuard, if you're not going to do your colonoscopy, fine, do the Cologuard. I think that's like not unreasonable, but as long as you know your data, right? Nothing is perfect, but just knowing like you could have precancerous polyps there that it does not detect. And anecdotally, as a gastroenterologist, I can tell you about certain things. So I have a patient who had refused a colonoscopy and had a Cologuard. He had a Cologuard probably about, I don't know, maybe 12 to 18 months before he finally decided to have a colonoscopy. Okay, and his Cologuard, so about a year before, was negative. And he finally has his colonoscopy with me, and he had like 20 large polyps. 20 large precancerous polyps, and the Cologuard did not detect that, right? So you just have to know, and if you're okay with that, then that's obviously your choice, but just know how good your test is. So recently, and this was big at the health fair. Did any of y'all go to that health fair that KCBD had at the Civic Center? Did y'all go to that? Anyway, so now there's this new blood test called Shield. And this one of all the tests actually really scares me for patients, because I worry that they have a false sense of security when they do this test. And so it is a blood test. The sensitivity for finding overall cancer, they said, was 83%, which doesn't sound terrible. But it only found 55% of stage 1 colon cancer. Right, so you could have a negative blood test and still have a negative Shield and still have stage 1 colon cancer, right? So I think like that's important to know. And in terms of sensitivity for precancerous polyps, 13.5%, right? So when we were at the health fair, we were there obviously trying to let people know about our GI group and colonoscopy and colon cancer screening. And we had patients come up to us and say, oh, I just had my Shield drawn. I just got screened for colon cancer. And I'm like, okay, that really made us dig into the data. I'm like, that's a test that you are gonna get done, and Medicare is only gonna pay for it every 3 years. That's also kind of scary, right? And you could have stage 1 colon cancer, and it's only gonna catch it 55% of the time. Like, you're basically flipping a coin, right, as to whether it's gonna be positive or negative. So something to consider, and just making sure, like, you know the data on the screening test that you are being offered. Okay, so the more fun stuff, the role of stress in gut health. Okay, so everybody has been talking about the gut brain axis, the brain gut axis, and it is so important. The gut and mind connection, right? The gut brain axis links emotional well-being with physical health and through lots of different signaling pathways. I'm going to kind of hit on those shortly. Stress activates hormones that influence your gut function as well, like cortisol, okay, and overall your digestive health. Stress triggers nervous system responses that alter your gut motility as well. Okay, so here's this is like the meat, very detailed things, okay? So activation of the stress response system. So you have the hypothalamic pituitary adrenal axis. So the brain releases corticotropin releasing factor, which signals your adrenal glands, which make cortisol to produce cortisol, okay? And cortisol does all sorts of things, right, to your body and to your gut. We know it can even worsen your risk of cardiovascular disease, right? So chronic stress is not a good thing. The sympathetic nervous system, okay, your fight or flight response, can also impact your gut bacteria, can alter your gut bacteria. And this can result in and it can also result in compromised gut barrier. So stress weakens your intestinal barrier. So you have these tight junctions, this mucus lining in your gut, in your stomach, in your small intestine, and you have these little tight junctions that basically keep everything out of your bloodstream from getting into your body, right? It's a protective mechanism. And so what happens, these tight junctions, okay, weakens that barrier, and this can result in that, what people are calling leaky gut, okay? So leaky gut is a very just like generic term, but it can actually, when we think about like Crohn's disease and ulcerative colitis, those patients actually do have quote unquote leaky guts, right? Like that, their lining is damaged, right? Their tight junctions are not fitting well. And so basically, we know that stress can weaken that barrier, okay, which can allow bacteria, toxins, food antigens to cross the intestinal wall and create like more inflammatory responses. It can also lower the production of beneficial metabolites like short chain fatty acids, okay? And that's what your gut feeds on, okay? It's on those short chain fatty acids that help maintain that gut barrier and reduce inflammation. So these are all things to know. So chronic stress can lead to symptoms like bloating, abdominal pain, changes in bowel habits. People with irritable bowel syndrome are certainly their symptoms will flare or worsen when they're stressed, when they have a major life event happen. One of the things I'll actually ask my patients, when a lot of my patients who've had every test in the world, and they're like, what's wrong with me? I have this pain and nobody knows why. I will ask, what was happening when you started to have this pain, right? And if you ask those questions, sometimes you find out they were going through a divorce, their child passed away in a car accident, right? And all of these things, are impacting their gut health now, and that's how that stress is manifesting in their gut. Chronic stress, can aggravate ulcers as well. So we know how stress impacts the brain. So the gut barrier is compromised. Bacterial products can basically enter the bloodstream, trigger inflammation in the brain, which can actually cause anxiety, depression. So basically, not just your brain impacting your gut, but what does your gut do to impact your brain? And that's what I was trying to get at with this slide. Okay, so serotonin, right? So serotonin, people who have anxiety, depression, what do they get put on? Like SSRIs, right? Medications that impact serotonin, right? 90% of serotonin is produced in the gut Isn't that crazy? That's impressive, right? It's like, oh my gosh, okay. We actually have some meds that we use for constipation that also act on your serotonin receptors, right? That is just showing you how connected, how strong this connection is. Okay, GABA. So gut bacteria also produces GABA, and stress-induced dysbiosis can interfere with GABA production, which also impacts your mood. So, right, so if your gut isn't healthy, we know that it can impact your brain, all right? There are patients who have what we call visceral hypersensitivity, where basically stress makes their gut extremely sensitive to pain and stimuli that might not otherwise impact you, but for them, it causes an intense distress and discomfort. And so we actually use medications that work on those serotonin, so psych medications to help with their gut pain as well. And it's probably the most effective thing we can do for them. Okay, so yay, all the things. So mindful practices, right? So meditation, right? Like doing things to calm your stress. That is very, very important. Exercising, right? We know movement makes your gut move, right? People who go running, right? They sometimes have to go to the bowel movement, have bowel movement after, right? That's why there's porta potties at marathons, right? You gotta like stop sometimes. Okay, so exercise helps lower stress hormones and promotes healthy digestion. Okay, making sure you're sleeping enough, right? So people who have obstructive sleep apnea, right, they have chronically elevated cortisol levels, right, because their bodies are so stressed from not sleeping well, from having low oxygen, probably in the middle of the night. So making sure you're sleeping, that you're treating your sleep apnea, those are all important things to do. Okay, where am I here? Okay, dietary impacts on digestive wellness. So now let's talk about the tacos, okay? Because that's what you guys really care about. I know. Okay. So spicy food irritation. Okay, so spicy foods can irritate, obviously, the digestive tract. We talked about avoiding those things, especially if you have reflux, ulcers, gastritis, like being aware of that. We know that if you eat food that is very high in fat, that actually takes longer to leave your stomach. Okay, and that can worsen your heartburn. So these are barbacoa tacos. Okay, I don't know who likes barbacoa tacos. This is one of my favorites. Very fatty. You have to be very careful. All right. Common symptoms triggered. So both spicy and fatty foods can trigger obviously heartburn. So you have to be like cautious. But tacos, they're not all bad. Okay, they're not all bad. Okay, so one of my favorite examples about the Mediterranean diet specifically. So tacos, when you put these veggies on them and use lean proteins, right? It's actually a very healthy option. Okay, so the Mediterranean diet fish tacos, comparing our normal beef tacos versus our Mediterranean tacos here, right? So red onions are great prebiotics, right? Avocado, prebiotic, high in fiber, it's a healthy fat, right? A corn tortilla, don't fry it, okay? But corn tortilla, just warm it up. Corn tortilla, high in fiber, right? Whole corn, it's gluten-free for those patients who might have celiac disease. And so a Mediterranean diet, I tell patients you don't have to eat Mediterranean food for a Mediterranean diet. Fish tacos adhere to the Mediterranean diet, which is the best diet for your liver, okay, which is the best if you were to ask any doctor, an endocrinologist, a gastroenterologist, a cardiologist, or to say, Mediterranean diet, that's what you need to follow. And so I feel like this is important. Not all tacos are bad, okay? Fish tacos, that's an option. Okay, so this is just kind of reiterating what we talked about, right? Physical activity, reducing your stress, because it really does alter motility. This kind of also got me down the rabbit hole of like menopause, perimenopause, and all of those things, and how even drops in estrogen and progesterone can actually slow your gut as well. And so I have some patients, I'm finally at an age where I have friends, or we're all going through this, right? We're perimenopausal, and it's like, okay, wait a minute. Why is this changing? Is this hormone related? And yes, I think a lot of it actually is, and it's nice to know that and to see the data. So, I think we're nearing the end. Fiber, so high fiber. I know that's what our mom told us, eat fiber. That's what I'm going to tell you as well. Stay hydrated, all things in moderation, obviously. Mediterranean diet is the best. So when to seek help, our picture is fuzzy. But basically, if you're having ongoing digestive symptoms, you really should get them looked into. Okay, if you have a sudden change, if you've been totally fine, and then all of a sudden you're having thin stools or any type of bleeding, you should absolutely talk to your doctor or come and see us. All right, I think that's it. Questions?
Oh, is there any hope?
Is there any hope? There's no, I mean, so I do think like it was very interesting because I had not done a talk like this specifically looking at aging, right? Like how does the gut, does it age? Does it really, right? Because sometimes we're like, okay, well, this is abnormal. Is this because you're now 80 or is this truly like there is something that went wrong? And so what I found really interesting is there are some things to know that, there are some things that are going to change, even normal and still healthy, you're still healthy, right? But I think if anything, like swallowing is the biggest thing, right? Like sometimes people have like, all of a sudden I can't swallow like I used to, or I'm choking and coughing, like those are age-related changes that are actually happening to you, right? And being mindful of that, but there are ways to take care of them too, right? Like speech therapy can work with you and give you tricks to help make sure you avoid aspiration, right? Or thicken liquids if it's thin liquids that you're having trouble with. So, there are changes that inevitably occur to us, unfortunately, but I do think that there's lots of things we can do to, manage them.
But you mentioned tacos, that's.
You can have tacos, fish tacos. Go ahead.
I was just curious, prune juice versus prunes themselves, like,
Yeah.
how does that enter into the fiber?
Yeah, so prunes themselves, I would definitely prefer. So I feel like especially if you're like buying prune juice, right? Like you're gonna get so much more fiber and bang for your buck from actually having the food itself, right? And minimizing the processed, right? Like juices are highly processed, sometimes have more sugar even than we want them to have, right? So I think if you can do the prunes themselves, that would be much, much better if you can do that. Now, if you're not gonna do that, then I would say, then do that, but yes.
Someone online is asking if you can comment about SUDD.
Oh, symptomatic uncomplicated diverticular disease, yeah. So, yeah, so basically that's what I kind of alluded to when people have that, so basically SUD, SUDD, symptomatic uncomplicated diverticular disease. That's what that stands for. And so basically people have diverticulosis and they can have all of those pockets, particularly on the left side. And we call it uncomplicated, meaning it's not infected or inflamed. They're there, but they're causing you discomfort. And we know that this happens if those little pockets just get stretched or you have more air, more stools sitting in them, and it can cause that discomfort. And so we will, again, make sure that they're having regular bowel movements, that they're not constipated, they're having high fiber diet, or if they need to be on more than just high fiber diet to make sure they're maintaining good bowel movements, that usually will help that SUD, as we call it. Mm-hmm. Yes.
Any studies done on organic versus
Non-organic.
non-organic?
Yeah, so I have not really dug into organic versus non-organic, right? To really kind of flesh through in terms of what, right? Like colon cancer risk or all those things. I was actually talking to a good friend of mine about 6 months ago about this because she's very, very healthy, and we did her colonoscopy and she had like 3 precancerous polyps and she's not even 40. And she was like, oh my gosh, this is all diet. And she kind of went down the rabbit hole of like, should I just be getting like grass-fed beef and like that whole thing. And I'm like, I do think like MD Anderson is probably doing some studies on this, because some of our patients have actually told us that when they go there for treatment, they're asking them about what was your, and which is also hard to know how good is your recollection, right? How many times did I get grass-fed, meat versus non-grass-fed? I don't know, like who did my shopping that week, right? So, but they are asking those questions, right? I do think like our highly processed foods are the reason we're seeing more colon cancer. And so I think eating from your garden is probably the best thing we could be doing. Not the most, everything is processed though, right? Even when you try to be mindful of that. But, if you can afford the organic, then do the organic. But I would say, even if you can't afford organic, just doing fiber and veggies and things like that, non-processed natural foods is the best way to go.
2 more questions.
Yeah.
And you may want to repeat it so that people online can hear.
Yes.
About 6 weeks ago, this person had a hysterectomy to remove a polyp and became more regular. She's wondering why this could be, and incidentally, her back pain also disappeared.
Okay. So, remove the polyp from her uterus, or a fibroid maybe. Okay, so to repeat the question, basically somebody had a hysterectomy to remove a polyp, but basically removed the entire uterus, which hard to know the details, right? Obviously of this patient situation. I will say, right, like if you had there are some patients who have very large things coming off their uterus, fibroids and things like that, that can be potentially impacting pushing into your colon wall, if you will. I had a case of that before, where I was doing this patient's colonoscopy and I saw what looked like something pushing into the colon. And I was like, what is this? Is this like in the wall of the colon? Is this outside the wall? And the CAT scan really wasn't as clear to us if that was happening. So she actually had a diagnostic laparoscopy to kind of make sure there wasn't like there's weird masses that can happen within the walls of colon. This is why she ended up going that route. And there was actually a huge fibroid that was pushing into the colon wall, right? And that was what that was, right? So it's possible that if her uterus was large or she had a large fibroid, that could have been impacting her constipation.
Okay, last question is, can you talk about causes and help for diarrhea?
Oh, causes and help for diarrhea. Oh my goodness, there's lots of causes for diarrhea, right? So, when you come and see us, right, like we will obviously look for, we talked about things like medications, infectious things. Most of the time, you would have already resolved. If it was infectious, you would have resolved before you come to me, right? But there are certain medicines that can definitely cause diarrhea. I have patients that have come to me with diarrhea, but they're taking magnesium for sleep, right? And they're taking the citrate kind, and that's causing them to have diarrhea, right? I'm like, okay, well, let's stop magnesium, because that's probably causing your diarrhea. So, there's lots of things that we would do. I would say the first thing, even for diarrhea, I would just make sure fiber supplementation is part of your diet. We give fiber to diarrhea patients and constipated patients because it promotes bowel regularity. So, but I think if it's chronic and long acting, long term, then probably talking to your PCP and then getting referred to GI for your diarrhea is very reasonable. Do you have a gallbladder? That's the other one. If you don't have a gallbladder, sometimes you get diarrhea right after that gallbladder comes out. So those are all things we can work through and help. Yes.
I had one question. You mentioned the visceral hypersensitivity,
Mhm.
and that you said there were drugs to help regulate that. But you didn't mention.
Oh yeah. So we will use things like tricyclic antidepressant medication. So like Elavil or amitriptyline, nortriptyline, desipramine, all of those medications actually work very, very well for visceral hypersensitivity. And so, and we use them not in high doses. We actually use them in very, very low doses. And we can titrate up if we need to, but, and those are probably the most effective thing we have for visceral hypersensitivity. Mm-hmm. Yes.
10 or 15 years ago, it became a fad for many younger people to take a photo of their food and describe their food for every meal. Have you seen a growth of a database will help analyze their health later. Say, here's the documentation, what I've eaten for the last 20 years.
You know, I know, like, we should like scroll their Facebook pages, right? I don't know of such a database, but that would actually, that's interesting. Maybe there's like an app, I don't know, that would track that for us and throw it into a database. Yeah. I don't know. I don't know of any studies that are looking at that specifically, but that is true. Everybody does take pictures. Young people do take pictures of their face.
Yes.
I know, so I was gonna ask y'all for a selfie. All right.
Well, I have
Yeah.
one question. What's your opinion of over-the-counter Imodium?
So I don't have an issue with an over-the-counter Imodium. I mean, I guess it depends on what the situation is. You know, I mean, I will tell you, like, if we have worked up diarrhea and it is there, what you have is irritable bowel syndrome with diarrhea, and you have to take your Imodium on a frequent basis, I would say once a day or several times a week, and we know that there's nothing else going on, we do not hesitate to say that is okay to do. As long as it's been evaluated and we are certain that we're not dealing with anything else. All right. Well, I hope this was,
Do you want to take a selfie with that?
yeah, would y'all? Okay, let's do it.
Like you're gonna.
Yes. I'm an old millennial, okay? An old millennial. 41 is an old millennial. Okay, let's see.
Oh, there. Okay. Here we go. Okay.
Ready?
Yay.
Oh, yeah.
You need to get in the picture. One more. Ready? One, two.
Showed up on my screen.
Yeah.
Look, can you see it?